Hello, my name is Dr. Justina McGregor, and this lecture is Evaluating Performance Bias in Randomized Control Trials. The lecture objectives today are listed on this slide. First, critically appraise a randomized control trial for bias and consider any bias effects on the interpretation of the results. Also, demonstrate the ability to accurately interpret and apply the results of a randomized control trial, considering what is known about the biases, risks, benefits, clinical context, and study population characteristics. Also, identify examples of performance bias in a randomized control trial and explain how to prevent it from occurring. Finally, explain the concept of blinding and why it is important for RCT validity. So let's begin by considering a case example. A vitamin C study involving 311 employees of the National Institutes of Health enrolled volunteers to take 1 gram of ascorbic acid or a lactose placebo in capsules 3 times a day for 9 months. At the onset of a cold, the volunteers were given an additional 3 grams daily of either placebo or ascorbic acid. 190 volunteers completed the study. Although there were no differences in the frequency of colds between the two treatment groups, there were distinct differences in decreased cold duration and severity favoring ascorbic acid. Could there be other reasons for this observed difference? Think about this and explain to yourself. Now, let's get a little bit more information. Early in the trial, the investigators discovered that some of the volunteers had bitten into and tasted the contents of their capsules and claimed to know whether they were taking ascorbic acid or lactose placebo because of this. The seriousness of this problem became apparent at the end of the trial when the investigators asked each participant to fill out a questionnaire that asked them to guess which substance they had been taking, and the results are shown here in the table. You can see from the table how many in each arm actually guessed the correct answer. And you'll see that there is a statistically significant distribution here. Now, just as a side note, Linus Pauling is probably the most famous OSU graduate. He was the only person to ever receive 2 unshared Nobel Prizes, and he received one in 1954 for chemistry and the second in 1962 for peace. He contributed greatly to the development of many chemical theories, and his theories around the health benefits of high-dose vitamin C were one of the areas in which he promoted a lot of aspects of pharmaceutical care. In a retrospective analysis, the differences between these groups that we've talked about today in all areas were eliminated when those who had guessed their medications were excluded from the study. Now, of course, this negates the intention to treat analysis principle and the randomization that could have been reducing any selection or confounding bias as well. So in that example, we were considering an instance in which the participants in the studies were inadvertently unblinded to the status of which arm of the trial they were enrolled in. And today we're focusing on performance bias. And if you remember from this diagram that we've shared with you earlier, performance bias are systematic differences in the care provided to the individuals in the study, apart from the intervention itself that is being evaluated. One way that these systematic differences between the groups can occur is when we have some awareness of what the intervention is that we have been assigned to, or which arm we've been assigned to. This can alter what the study subject's expectations are for their own outcomes, i.e. it can differentially have a placebo effect or take away the placebo effect. Patients are more likely also to comply with whatever they've been assigned to if they think they're receiving the study drug. And they're less likely to be lost to follow-up if they think they are, if they're unaware of which arm they're in, or if they think they have received the study drug. Now, systematic differences between groups can also arise when the care provided to those groups, the healthcare or the course of their management of their disease state, differs between the two groups. So if there is some differentially administered co-intervention, such as rescue medication use or other medications used for other disease states, or if there are different schedules for adjusting dose, different dose escalations or titration schedules, this can lead to differences also between these two arms and contribute to performance bias. And it's important to recognize that performance bias can actually affect the outcomes of the trial, even alter the probabilities of mortality. Blinding is an important aspect of preventing performance bias. When we talk about blinding, we're talking about keeping involved persons, that could be patients, investigators, study monitors, etc., in the trial unaware of the treatment allocations until the study has ended. And as I just stated, blinding helps to prevent performance as well as actually detection bias. In order to maintain blinding, we must make sure that the control looks, feels, smells exactly like the study drug, which, as you could tell from the example with the vitamin C and the placebo, can be challenging. A lack of blinding is associated often with exaggerated intervention effects, and more bias is noted for subjective outcomes rather than objective ones. So let's take a second to think about, how does allocation concealment differ from blinding? We talked about allocation concealment in an earlier lecture. So this figure here just outlines the general flow of the randomized control trial from left to right, where we have some study sample recruited and consented to participate in the trial. And then there is a process of allocation of identifying which subjects will randomly be assigned to either the treatment or the control group. They're followed over time, and their endpoints or their outcomes are assessed. Blinding happens throughout the study period from the point of allocation onward. So from the point in which we have the subjects allocated to treatment groups and they are undergoing the trial procedures and plans. And this helps us to prevent both performance and detection bias. Allocation concealment occurs during the process of allocation. So from the point at which we are consenting patients to the point at which we are assigning them to the group, that process of concealing who goes into which arm helps maintain true randomization. That is allocation concealment. So you can see on the figure here, just sort of within the time sequence of the trial, where allocation concealment occurs and where blinding occurs. So again, allocation concealment is sort of before the trial procedures and study visits begin for the patients. It's always something that is achievable if appropriately planned. And if it is not achieved, if it's not implemented correctly, it leads to selection bias. Blinding begins once the trial begins from the perspective of study subject visits, encounters, measurements. It's not always achievable because of the characteristics of the intervention. It may not be able to create a placebo or equivalent arm. And a lack of blinding can lead to performance and/or detection bias. So it's important that we're familiar with different terminology that refers to blinding when we're reading clinical trials and critically appraising them. Non-blinded, often referred to as open label, is what happens when everyone knows who receives the experimental treatment and who receives the control. Single blind refers to the situation where patients only do not know which treatment arm they are allocated to. Double blind refers to patients and study investigators both not knowing which arm of the trial study subjects are assigned or allocated to. There is some reported variability in this, though. It is important that the protocol and/or the publication clearly outlines what is meant by double blind, which study investigators, which study staff, outcome assessors, clinicians are specifically blinded. In one evaluation across 200 randomized control trials, there were 18 different possible combinations of double blind. And so really it is better to explicitly report the blinding status of the people by the role that they have in the study. Finally, triple blind refers to the additional step of the statistician being blinded to the data analysis. The addition that the statistician is blinded during data analysis. And this also helps prevent reporting bias. So how does blinding impact the outcome? Well, if we think about subjective outcomes, such as the assessment of pain, patient, healthcare provider, and assessor blinding is very important to prevent both performance and detection bias, since any preconceived thoughts or notions about which arm they're in may impact the reporting of pain. Objective outcomes can also be impacted. Performance bias tends to be the main concern in these scenarios, as it is possible that differential care received by study subjects may actually impact the outcomes themselves. Typically, we want to make sure when we're appraising a trial, we assess the risk of performance and detection bias for each outcome. We need to think about who was actually blinded in the trials and consider all persons involved in the study protocol implementation, and so that we can evaluate for ourselves who should be blinded. Let's consider this example provided by the consort group. Jamieson Laboratories Incorporated provided 500 milligram immediate release niacin in a white oblong bisect caplet. We independently confirmed caplet content using high-performance liquid chromatography. The placebo was matched to the study drug for taste, color, size, and contained microcrystalline cellulose silicon dioxide, dicalcium phosphate, magnesium stearate, and stearic acid. So this is just an example here that represents what we want to see. Authors should clearly be stating the similarity of the characteristics of their intervention to their control, including characteristics such as appearance, taste, smell, and method of administration. It's important to recognize that there are some situations that can make blinding incredibly difficult. For example, unique side effects may be very difficult to blind. Beta blockers have a notorious side effects of making people feel kind of generally uneasy or unwell. Zinc lozenges, subjects can report that their mouth feels galvanized. It would be hard to mask that in a placebo. Niacin, flushing that is reported with that can be, all of these things can be hard to overcome and may be impossible, in fact. Also, if there are different routes of delivery, it can be incredibly challenging. For example, if we have a standard of care that is delivered through the tablet, we want to evaluate it against a patch. What do? Well, sometimes instead of just having a single arm, we're having a double dummy technique where both arms receive a dummy or placebo in the alternate formulation. So the active patch group would receive a dummy or placebo tablet, and the active tablet group would receive a dummy or placebo patch. Now, trials of surgical procedures or other sort of procedural interventions are incredibly hard to blind. Sometimes sham surgeries have been employed, but only the patients and post-surgical caregivers can actually be blinded. Obviously, the surgeons or the persons actually involved in administering the intervention cannot be. So to wrap up, it's important that we evaluate randomized control trials for performance bias. We want to assess if there are any study differences in how the patients received their care or were managed across the process of the study between the study arms, any differences other than the intervention itself. And it's especially important for us to evaluate study blinding. Who in the trial is reportedly blinded? Are there other challenges to the blinding that is specific to the intervention under study, characteristics of the study drug or intervention that may make it impossible to accurately maintain a blinded state during the course of the trial?